Good evening, everyone. Thank you for joining the Diabetes Foundation Aotearoa Diabetes Summit number 2. I'd like to start by introducing and welcoming my co-chair, Dr. Materi Harwood. Materi, it would be rather nice if Materi could start the proceedings with a prayer.
So, kia ora tātou ngā maruhiri. Te mea tuatahi, tuku whetai mō miti ki tō tātou kaihanga, tēnā koe. Ka mihi ki ngā whenua, ki tō tātou e noho ana, tēnā koe. Ka mihi ki a rātou kua haere ki te whetū rangatia, haere, haere, haere rātou. Hoki mai anō ki ngā kanohi ora, tēnā koutou, tēnā koutou, tēnā koutou katoa. And I'd like to welcome everybody and start tonight's proceedings with a karakia. He honore, he kororia ki te atua, he maungaroro ki te whenua, he whakaro pai ki ngā tangata katoa, haumi e hui e, tai ki e. Kia ora.
Thank you, Materi. These are very difficult times. We had hoped to be able to hold the session at the Papakura Marae, which is a truly iconic venue, and with a live audience, but unfortunately COVID-19 has intervened, and so we're left with a webinar, which at least for me is a very strange medium. Talking to rather a lot of people out there, I understand, but no perception of the audience in front of you. I'll just talk very briefly how the session will work. So we have 2 guest speakers. There's Professor David Simmons from West Sydney University in Australia. We'll start with a talk about the diabetes audit. This is a follow-up from last year's presentation, and he will be followed by Dr. Janek de Soiza, who's an eminent renal physician, and Janek will talk about diabetic kidney disease in New Zealand, Aotearoa. And then after that, we'd like to welcome 4 political candidates who've kindly agreed to join us tonight to talk about their own experiences of diabetes and to talk to us about their view on what can be done for this serious problem for our community. And we hope that in that second half of the session, we will have question and answers. Our politicians have kindly agreed to answer questions from the audience. And this will come to us through the chat link. Materi, do you want to make any comments before we start?
No, just to encourage people to take or to send through their questions as we're going along so that we have a really robust discussion at the end. I think it'll be fantastic. That was how we ran it last time, and I think it was really useful.
Thank you, Materi. So without any further delay, we should cross to David Simmons in Australia to hear an update on the diabetes audit evaluation. David.
Thank you. Hello, everyone. Thank you, John and Chair and candidates. Kia ora tātou, talofa lava, malo alele, kia rana, and pakalofa laiatu. And it's good to be here to try to further the goals of the first South Auckland Diabetes Summit, to try to see how we can deal with what's really considered a wicked problem that's been here for a long time and seems to be continuing. And my role is to provide some insights from the past and some evidence for some future, for some things that can be done, because we want to look forward and look for positive things. So just as a quick quiz, hands up if you know what the greatest epidemic is in human history. Is it the Black Death with 75 to 200 million people passing away? The Spanish flu or COVID-19? You don't have to answer. And the answer is, it's the diabetes epidemic. It's the largest pandemic ever seen. So this is how many millions of people have diabetes diagnosed and have diabetes every year, and it's been going up, and this is just since 2000. So we know that this is the largest pandemic. You think of the number of people that have been lost. And what we also know is that we predicted this back in the 1990s, and we said action must be taken. These were our predictions. We predicted that there'd be 150,000 in New Zealand Aotearoa, and actually the ministry estimates are 253,000 currently. So we understated the case. And then where would you think the largest number of where do you think the largest number of people are, proportion of people with diabetes are? It's our own counties Manukau. So this really is the hotspot where we need real action, and we need it now. We've actually needed it now for over 20 years. And a lot of work has been done. We started off with my mentor, Dr. David Scott, from 1983. And I remember that time when we had people walking in with end-stage renal failure. We had stillbirths, increasing numbers on the wards, high numbers of amputations. It really was terrible in terms of diabetes. And he established Whitiora Diabetes Clinic, the South Auckland Diabetes Centre as a community diabetes centre, diabetes in pregnancy clinics, and also recognising the particular cultural skills that there are a range of Māori and Pacific community educators and a whole range of other interventions. And based on that and data, we then had the diabetes plan in 1992, the first district diabetes plan in the world, actually, to improve the lives of people with diabetes, having prevention with those for the whole population as well as high risk, information management, quality improvement in primary care and secondary care, different strategies. How do you overcome barriers, those hurdles that people face? How to improve the care of people when they're in hospital, and improving the access to specialist care when they needed it. Not just the management, but their eyes, their feet, access to dietitians and education. And since that plan, there have been other things. There have been our own Diabetes Foundation Aotearoa, something called the Diabetes Care Support Service that has data which will show you what's been going on, and a range of programs to try to prevent diabetes in the community. This is not an easy task anywhere in the world. Nowhere has turned it around through lifestyle programs. These are very complicated. People lead very complicated lives. But there was investment in South Auckland with Let's Beat Diabetes, community teams. There's at the moment a localities approach, which is general medical. It's not diabetes specialists supporting GPs necessarily, and a range of other initiatives. But our Diabetes Care Support Service has been collecting data and trying to provide good advice and information to GPs onto how they can improve their care, but it's only in broad terms. And this audit actually has had 79,912 people through, of whom 3,030 had type 1 diabetes. That's the sort where you're dependent on insulin therapy to survive within the next 1 to 3 days. And type 2 diabetes, 47,000 people, where it slowly sticks to parts of your body and slowly they begin to fail and are damaged if you don't get that glucose and blood pressure and blood fats under control. And I just want to flag that what I'm showing you are unpublished data, they're preliminary data, but they're very important to show what's been going on. We have 25 years of data as people have tried to deal with this in different parts. And what you can see here is European, Māori and Pacific people. The turquoise is before 1998, orange, grey, yellow and blue, 5-year blocks up to 2018 when the funding for this stopped. And you can see how many people were being hospitalized for cardiovascular disease, so heart attacks, heart failure, those things, each year. And you can see this massive increase from just, about 25 per 1,000 person years, tenfold over this period of time, this hospitalization. This is what South Auckland, Counties Manukau has been facing. And end-stage kidney disease hospitalisation, and my colleague Janak will talk about the dialysis aspects, it's a mirror image. Look at these huge numbers that are increasing over time per 1,000 person years, which means if you have more diabetes in the population, these numbers are indeed will be a lot higher because this is based on per 1,000 person years. But a key part of this, and a terrible part of it, is that the average age that Maori and Pacific people have their diabetes diagnosed is 10 years younger. So this starts 10 years younger, when people are often physically fit and active in their lives as they lose their ability perhaps to contribute as they would on the marae in the church and their workplace in the community. So this is what we've now had the analysis for. This is the age at the bottom. And you can see that for any given age, then Maori in particular have much more people dying with their diabetes from any cause. So any cause, not just diabetes itself, not just the kidney failure, but this is across all. Look at this, what's happening in the younger ages here. And of course, we all meet up when we're older. If we look at that cardiovascular hospitalization, then what we can see here in yellow are those of European descent, red is Pacific and blue is Maori. But in these younger people here, you can see that the hospitalization is also twice as much. This is in spite of all of the things and all of that work that's been going on. And here, which I think is probably one of really the worst picture that we can see, is the end-stage kidney hospitalization. This younger area here is because this includes, we think, people with type 1 diabetes, and you can see how it is there. But look, if you're 50 years old and you're someone of European descent with diabetes, then this is the rate of your kidney, end-stage kidney hospitalization. And at this age, it's 5 to 10-fold among Maori and Pacific people. So these are really high rates. And this has been going on, well, we can show you, for 25 years. Particularly the last 10 years, there's been no change. So why is this still happening after 25 years of all of this work? So first thing, and I'm sorry to give you a little bit of health stuff. This on the left, these are red cells that bob around in your blood and they carry oxygen and things. When you take blood, that's why your blood's red. And sugar can stick. If the sugar is high in the blood, a lot of it sticks to your red cells. If your sugar is normal in the blood, only a little bit sticks. And we measure that through HbA1c, and it measures the last 3 months because that's how long red cells live. And what we know, whatever ethnic group you are, wherever you're from in the world, then the higher that sugar sticking is, the more chance you have of complications. So if you run along at 86, for example, and I'll show you what that number may mean, over 7 years, then about 20% will develop complications. If you run at 53, which is still higher than the background, your rate is only 1 or 2. That's a 10-fold rate. Okay? So here's type 1 diabetes, which is uncommon, but still happens. We know over this time that the measurement of this HbA1c test has improved. A lot of care has improved, but it's been steady for the last 10 years or so. And here you can see in the yellow are those of European descent, and this is the average HbA1c for those with type 1 diabetes over this period of time. You can see nothing has really changed. The target is that 53, and that is that purple 86 with 10-fold rate of complications. And you ask, why do Maori and Pacific people have higher rates? This is one of the worst in the world, actually, for those HbA1cs in type 1 diabetes. And that's a specialist service requirement. Now, there are lots of barriers in our lives which may stop us from looking after ourselves, and lots of barriers also for healthcare providers to provide that care. And the medications we use are part of that. If people have side effects, they're less likely to take it. If they put on weight, if they have low blood sugars, it may be that there are cost issues. It may be that people have problems with actually taking it every day. We know that. We also know in our trials and things that Maori and Pacific people will apply things in the same way as those of European descent, providing that the care is appropriate. Then we know that people will follow things. We have a lot of studies around that. And we know when people lower their glucose, their HbA1c, we know that it lowers the complications. So would that be peripheral vascular disease, that's filling up of the arteries to the feet, which leads to amputations. Eye and kidney disease, it's down by at least a third. The deaths, cataract, cause mortality. So you get that sugar down in the blood through medications, through lifestyle, the things that you need to do, the monitoring, we know that these changes will have their effect. And we know that it lasts not just for 10 years, but lasts for 20 years. And those older studies were with the older drugs. And now we have better drugs. We have things called GLP-1 receptor agonists. And this is one study showing we can reduce the death and heart attacks and strokes with these drugs over time, something called semaglutide, unfortunately not available in New Zealand. We know that these don't have the same side effects. They don't have the weight, they don't have weight gain, they have weight loss. There are people who are very happy to take these drugs if they can lose weight, and it has no hypos, not in New Zealand. And there's another group of drugs called SGLT2 inhibitors, associated with a reduction of a third of cardiovascular death, all-cause mortality, heart failure, hospitalization, and my colleague Janak will also talk about their benefits in kidney disease. They are again associated with weight loss, no hypos, a pill you take, pretty easy stuff, few side effects, not in New Zealand. These are available all over the developed world now. And that getting that glucose down is so important. And when you look at primary care, which is what that diabetes care support service was the data was coming from, you can see that primary care is very good at achieving the blood pressure targets. Here's the systolic and blood pressure targets. You can see that they are equivalent between Maori, Pacific, Europeans, Asians. You can get to a blood pressure target because they're pretty, it's not easy necessarily, but for most people, you give them a pill, that's what happens. Diabetes is not like that. It's got a lot of lifestyle change, it's got glucose monitoring, it's got the medications, it's got a lot of more things. It's much harder. You need a lot of support to do that. And on the right, you can see what happens with the HbA1c. There's our target of 53. And what you can see up here is you can see that Maori and Pacific people for the last 10 years, here's those initial improvements that we had, which was wonderful. We no longer had those people walking in renal failure. But over the last 10 years, there's been no change. There's been no improvement with all of those things going in. And they're still running at this high rate of 64 associated with all of those excess complications. So why is this happening? So primary care needs support from specialists when you've got more complex cases. They need those medications and know how to use them. And this is data from Wing Chan, population physician who I don't think is on the line, but hopefully he is. And what you can see here is very few people in counties Manukau get access to specialist services. It's about half the other areas, and frankly, it's actually less than we would see elsewhere anyway. So there's a major problem in counties Manukau, not only in getting the drugs, which is something which we require across the country, but also in particular in accessing specialist services. And where is it that there's the greatest need for these medications and for the advice that the GPs can receive from specialists? They don't need to see people, as I'll show you. You can give advice directly to the GPs for those patients. They can still keep seeing their GP. You can see that the greatest demand is in counties Manukau. Look at that. It's half of the people with a high blood glucose in Auckland are in South Auckland. So what needs to happen? And this is looking to the future. So I'll take you through things one by one, but obviously we want diabetes prevention, but we know this is very complicated. Weight management is actually under endocrine control. The decisions we make are not as simple as we thought. A lot of it is also genetic when people make decisions, but people need support. It's a long-term strategy, complicated, but through schools and through communities. We can now put diabetes into remission with substantial weight loss. I'll show you some data. We need the ability for GPs to prescribe these newer medications. They're easier than insulin. They don't need to be taught about how to inject the hypos, all that sort of stuff, much easier. No hypoglycemia or weight gain. and integrated diabetes care. We want the GPs to have advice when the patient's in front of them, when they've got their records. It can take 5 or 10 minutes to give the GP advice, long lasting. I'll show you the data. And then patient access. If the GP says, look, too complicated for me, I've gone as far as I can go, it only takes 1 or 2 consults, and then they can go back to their GP. And of course, the Diabetes Care Support Service, we need a monitoring system, and there are those being developed. Is there evidence in New Zealand for preventing at least the obesity gain in children? There is something called Project Energize in the Waikato, in many other parts of New Zealand. It was briefly, I think, in Franklin District. And this is among Maori and European and some Pacific people in Tokoroa. And you can see that, this is Ministry of Health data, the proportion of children who are overweight or obese dropped in the Waikato by 7% there. You can see a big drop there. Across the country, no change. And the feeling is this is because of these energizers going in and working with the schools to have ways to get people to move more and get the children to eat more healthily. And then this is from Sydney, but it's built upon the work we did in Otara and Mangere, the Pacific churches, and on the marae in South Auckland as well, a number of them. And what you can see with what we've learned, and also in the Waikato, you can see that through the church program, you can improve that HbA1c significantly in a way to prevent people developing diabetes itself. And then for those with diabetes, the drop there was 7 millimoles per mole. That would be about a 10 to 15% drop in complications, even in the short term, through the lifestyle programs within the community, through having peer support and someone who would help coordinate. So we know these things can happen in Pacific people. We've also seen them among Maori. We know it can be done, but it's a longer term strategy. What about those with diabetes? Well, now we have evidence here and it's coming through all over the world. We've now just started it in our area with something called the DIRECT program, where with a 15-kilo weight loss, you can see that you can halve the number of people with type 2 diabetes over 12 months, and it's still a reduction by a third in 24 months. We can turn the corner and bend the curve, as we call it, with this kind of approach. And it's basically support for GPs to deliver this near to the home of the person with the type 2 diabetes. And these people come off those drugs, even if they still have their diabetes. And then we can have a specialist goes into the GPs, goes through, or even by telehealth, goes through the patient's notes with the GP, takes 5 or 10 minutes. And again, Western Sydney down by 9 millimoles per mole. Hunter, New England down by 5. We're doing this locally, it's down by 9. It's wherever you take it, it does the same thing. It's away from the patient usually, so it just takes a bit of time. And then the GP carries on with that plan for the next year. Very easy, very quick, but you've got to have the staffing. You can have just a consult clinic, 1 or 2 consults. And then what happens is, again, you can reduce the blood pressure and the HbA1c. It doesn't take long, 1 visit or 2, once the GP feels they're not able to cope. And it lasts for 3 years. Look at this. It's sustainable. Just 1 or 2 visits. That's all you need to invest in if you are the health minister, for example. And then for those with the highest, those HbA1cs that are really high, particularly among Maori and Pacific people, but anyone who keeps on coming into the hospital with their type 1 diabetes, you can case manage them. This is about readmissions. They were very high. We case managed them. We lost the funding, goes back up again. Dependent people, 60% have mental health issues. The right person doing the job that make a relationship, this can be done. It's not impossible. We can turn this around. So to summarize, South Auckland is a diabetes hotspot with substantial excess morbidity, mortality, and sorrow. You will know this due to the diabetes. We can turn it around. Primary care have managed blood pressure and cholesterol well, but glucose control, the long-term harbinger of death and damage, needs access to evidence-based tools currently unavailable to them in Aotearoa, New Zealand, and South Auckland, in counties Manukau, or the people with diabetes. Well, access to current care is comparable between the different groups, Maori and Pacific people have greater need of these additional tools. So we would recommend, we need time is invested in. We need the resources for these new medications. And really, for me, from now in Sydney, I look and I have to say that the lack of access to these two medications, something across the whole of the OECD, I think it's a national scandal. I remember the Hep C screening scandal, and I think this is comparable to the number of people who are being harmed because they don't have access. We need specialist service investment to advise and support primary care. It doesn't take, you can have one person can help hundreds of patients by going through the GP through that advice. The specialist service investment for those at the highest risk, and ring-fence primary care investments, they have time for these remission services and that diabetes care, and they're not diverted to other things. And meanwhile, we need new strategies for prevention, and we need that diabetes outcomes monitoring service like the DCSS. And I'd like to thank the team. Thank you. And if you want more evidence, naturally, I have to talk about my book. Thank you. Over to you, John.
Thank you, David. We have time for just a few questions of David, if there are any questions from the audience.
Stunned.
What is the incidence of gestational diabetes and how should we intervene?
So we have a question here from Elaine Rush. What is the incidence of gestational diabetes and how early should intervention be?
Thank you. Thank you very much, Elaine, and hi, kia ora to you. So gestational diabetes in New Zealand uses higher criteria and a less sensitive screening method than around the world. So the standard approach around the world would give New Zealand probably around, on average, about a 10 to 13% prevalence of gestational diabetes, possibly up to 20% group. And we've now found that about half of people actually have their gestational diabetes at the beginning of the pregnancy. And already in New Zealand, there is a screening for early high glucose type 2 diabetes and a few others as well. And in some ways that's positive. There's discussion about how that should be done, but that screening is early. But really we should be screening probably with glucose tests rather than the current test of HbA1c for a number of reasons. But there is screening already, but we also need not only to screen people and manage them, but when they have completed their pregnancy, this is probably the highest risk group for going on to type 2 diabetes. And they need help afterwards to try to work with them with all of the strategies we have, including even case management if we need to prevent that gestational diabetes progressing to type 2 diabetes at a young age, which we know is associated with heart disease, perhaps in the 40s and 50s, and their type 2 diabetes in their late 30s, 40s and 50s, and of course losing perhaps 10 to 20 years of their lives. So this is a key, really important group, and the screening is there, but the follow-up afterwards is limited. Counties Manukau did introduce a texting program, which has had some benefits. It's great that that's been acknowledged, but it needs more. Thank you, Elaine, for that question.
Just one other question here, David, from Rinky Murphy, with a comment really. Text-based support could be another cost-effective method of getting more people with diabetes to target. Do you have experience of that?
So there is some evidence for text-based support, and it does help with lifestyle. It certainly helps with things like smoking. And we actually have a trial starting soon looking at 4 women, and this is in Sydney, 4 women with gestational diabetes for supporting their physical activity and healthy eating with giving messages. There is some evidence for that, and I think it is one cheaper strategy to really turn people's lives around personally. And of course, it's hard in the COVID-19 world, but really people need some face-to-face support. And then in between, they have those texts. People need a lot of help to help them maintain initially the gaining of the weight loss and then maintaining that weight loss. And we know that that can be done through peer support. There's evidence of that from randomized trials. We have another one here. in Sydney, and also they also need coaches. This needs investment in people, but one of the good things is this is jobs, and it's jobs in people with those cultural skills. So we would very much like to see that. We did start that early on in the 1990s, and it would be great to have that built, that expertise built upon. Thank you.
Thank you, David. There are some other questions, but I'm quite keen to let Janik have his time to speak. So we'll close that session and go to Janik now, who will speak about diabetic kidney disease in New Zealand, Aotearoa. Welcome, Janik.
Thank you very much. And thank you to the Diabetes Foundation of Aotearoa for the opportunity to speak. I'm not sure if I've got the right slide showing. So I'm a nephrologist, and one of the most significant complications of diabetes is end-stage kidney disease.
I need Janik's slides. Okay.
So, try that again.
I've lost the questions there. I don't think David's gone.
Is that showing?
Yes.
Okay, sorry about that. So thanks very much to the Diabetes Aotearoa Foundation. And I've got no conflicts of interest to declare. So end-stage renal failure is a terrible disease. And what we know is that the incidence of end-stage renal failure is progressively increasing. Last year, approximately 600 New Zealanders developed kidney failure. So approximately 11 patients per week needed to start kidney treatment. Some of these are old, but many are young. Approximately 40% of patients under the age are under the age of 55. And the major cause of end-stage kidney disease is diabetic nephropathy, which just under half of our patients who develop kidney failure is due to diabetic kidney disease. This epidemic of kidney failure is projected to progressively increase. So currently we've got about 3.5 million patients on kidney treatment, and it's thought that this will progressively increase to almost 5.5 million in the next decade. Much of that growth is in other countries, but we think that this growth will increase by 3 to 5% per year. When you have kidney failure, it's a terrible disease with awful outcomes. The average survival is about 3 years when you develop kidney failure. And the only effective treatment which will change that course is a kidney transplant. But many patients who develop kidney failure cannot access a kidney or are not fit enough to receive a kidney transplant. And to highlight David's point, this disease affects different ethnicities disproportionately. So if you're a Maori or Pacific person, your rate of kidney disease is increased by 3 times amongst New Zealand Maori, and by 5 to 7 times amongst Pacific people. And the majority of that is due to diabetes. When we look at Europeans, approximately 28% of Europeans who develop kidney failure is due to diabetic disease. But amongst Maori and Pacific Islanders, 70% is due to diabetes. So therapy that would control diabetes would significantly benefit all New Zealanders, but especially Maori and Pacific people.
Yeah.
This slide really highlights the impact of diabetic kidney disease. And so if you develop kidney disease in your 30s, it will shorten your life by six years. If you develop diabetes in your 30s, it will shorten your life by 10 years. But the combination of diabetes with kidney disease will shorten your life by approximately 16 years. If people do develop diabetes and kidney disease, the standard of therapy, as David has highlighted, is really to get tight control of their diabetes and their HbA1c, and that can slow damage to the kidneys. Additional therapies include agents such as the angiotensin receptor blockers. And we knew this from almost 20 years ago, that this class of drugs can reduce the incidence of diabetic kidney disease and progression to end-stage renal failure by about 20%. Since then, there have been a number of other trials which have been shown to be ineffective at treating diabetes. And throughout the 2000s and the 2010, there are a number of agents which really were proven to be ineffective. However, more recently, we've identified classes of drugs which may be shown to have benefit. And David has touched on these. And what I'd like to do today is really go through some of these classes of drugs and present the evidence to you, and really highlight these medications in the context that they're unavailable and unfunded in New Zealand, whereas they are available throughout Australia and other OECD countries. So the first class of drugs is the SGLT2 inhibitors. And these drugs act on the filtering units of the kidney and stop reabsorption of glucose back into the body. And by doing so, lower blood sugars. In addition to reducing blood sugars, they're thought to have many other beneficial effects which can help the kidney. They reduce pressure on the filtering units, they reduce protein leak, reduce blood pressure, and have a beneficial effect on the structure of the kidney itself via inflammation and fibrosis. Now, there was a meta-analysis, a pooling of multiple trials that look at how this class of drugs may help the kidneys. And the pooling of these studies included over 38,000 patients, so big numbers of patients. And in general, these patients were treated with the SGLT2 inhibitors or standard of care. Now, put it into context, these medications started to be used in the early 2010s, and initial trials targeted groups of patients who were at low risk of developing kidney disease and really focused on the safety of these drugs. However, more recently, these trials have focused on patients who have high risk of progression because they already have underlying kidney disease, marked by a reduction in how well their kidneys are working or protein leakage. And what they've shown is, in terms of key outcomes such as the need for dialysis, the need for kidney transplantation, or dying due to kidney failure, that this class of drugs can reduce those outcomes by a third. So the risk reduction is 0.67, approximately a third reduction in dialysis, kidney transplantation, or death due to kidney failure. If we drill down on that, we can see that there is an improvement in patients who develop kidney failure, an improvement in patients who will have a 40% decline in their kidney function, kidney failure, or die because of kidney failure, and a reduction in all of those outcomes and death due to a cardiovascular death, a heart attack or a stroke. And we see that consistently with this class of medications. One of the concerns with patients who use older drugs is developing acute kidney injury, a sudden decline in kidney function. And what we can see in terms of safety is that the incidence of acute kidney injury in patients using this medication, this class of medications, is also significantly reduced. So the SGLT2 inhibitors are associated with much better outcomes in terms of patients developing the need for dialysis, kidney transplantation. They have an improvement in terms of slowing progression of kidney failure. They have an improvement in terms of cardiovascular death. And there's drugs that are safe, that they reduce the incidence of acute kidney injury. As I mentioned, much of the evidence from this class of drugs comes from the Credence study, which was published just last year. And this trial recruited patients who were on average 63, and it did well preserve renal function. And what we could see is that patients who were treated with placebo, the standard of care, had a decline in their kidney function of 4.5 mils per minute. So between the age of 63, they would reach the need for renal replacement therapy, the need for dialysis, at about age 73. If, on the other hand, they were treated with the SGLT2 inhibitor, that decline was significantly slowed. And they would only need reach the need for renal replacement therapy at the age of 88. So we saw a saving, an impact on the patient of deferring the need for kidney treatment, dialysis, or a kidney transplant by 15 years. The second class of drugs I'd like to touch on is the GLP-1 receptor antagonists. Now, again, we have a meta-analysis which includes patients from major trials and looks at kidney outcomes. And what we can see is patients who are enrolled in with this class of drug have approximately a 20% risk reduction in developing protein leakage, a significant decline in their renal function, the need for kidney treatment, dialysis or a kidney transplant, or death because of kidney failure. Much of that was due to preventing development of proteinuria. And when we look at the need for kidney treatment, that effect is less marked. Again, this trial tended to, the major trials tended to enroll lower risk patients and focus on safety. And when we look at the LEADER study, which enrolled 9,000 patients, who were at higher risk, what we saw was that there was a significant improvement in renal outcomes, particularly driven by the development of proteinuria. And we also started to see some improvement in terms of preservation of patients' kidney function. The final class of drugs that I'd like to touch on are DDP4 inhibitors. And these are beneficial agents in terms of tolerability and preventing weight loss, which David has highlighted, attractive to patients. These studies have shown that they're equivalent in terms of controlling blood sugars and are particularly safe in terms of kidney outcomes. Larger studies which have focused on cardiovascular benefits have also shown improvement in terms of renal function and significantly have shown some benefits in terms of proteinuria. So what do the guidelines suggest we should be doing for patients with diabetes and diabetic kidney disease? Well, the International Kidney Disease Guidelines and Diabetes Guidelines is due to come out next month. So I'd like to tell you about it, but unfortunately it's not officially in press. But I can tell you the draft guidelines are very much similar to the European and American consensus status statements, which I'm going to present now. The European statements suggest that patients should initially be treated with metformin and try and achieve a target HbA1c of 7 or less. However, if patients cannot tolerate metformin or can't achieve target, then they should use the SGLT2 inhibitors. And that's because there's benefit for kidney protection. And what I haven't told you is that there's also similar evidence for heart protection. If an SGLT2 inhibitor is not tolerated or it's not working, then the suggestion is that we should use GLP-1 receptor antagonists. And if those drugs are ineffective or not tolerated, or the patient remains above target, then we should use medications such as the DD4 inhibitors. The American Diabetes Association guidelines suggest for second-line therapy, i.e. after metformin, that the SGLT2 inhibitors should also be used, especially in patients who have renal impairment or have significant protein leakage. And that's on the basis of these drugs slowing progression of kidney disease, as well as having a cardiac benefit. So I'd really like to highlight that the SGLT2 inhibitors have a significant impact in terms of preventing progression of kidney disease. And that's true for patients who have all levels of kidney impairment. In addition, this class of drug is safe, and there are future studies that are soon to be published which will confirm whether this is a class effect and widen the potential drugs that can be accessed. The GLP-1 receptor antagonists also have some benefit in terms of CKD progression, and as a class is shown to be safe. And the DDP4 inhibitors, although not shown to slow progression of chronic kidney disease, are effective and safe drugs in patients who have renal impairment. And really, I'd like to echo David's plea of access of therapies which would help patients to achieve these targets and prevent terrible complications.
Thank you, Yannick. That was fantastic. Yannick, we do have some questions here and time for them. So there's a question here. It's an anonymous. Oh, it's gone. Have you measured the effects of diabetes nursing case management? I think that's more a question for David, if he's still on the line.
Yes, I'm still here. And the case management that we had for those who were high flyers, they reduced hospitalization by 60%. They reduced that HbA1c in the short term even by 11 millimoles per mole, and it was still going down afterwards by about another 5. And it also improved their well-being and improved their attendance by doing that, using those case management. The case management that we had educated by those nurses who were high flyers. So it certainly has a role. They reduced hospitalization by 60%. So we use this approach. They reduced that HbA1c in the short term even by 11 millimoles per mole, and it was still improve their attendance by doing that, above that, and then you the case management that
I'd echoed David's comments. we have had case management driven by nurses, and typically we've focused on a combination of both blood pressure control and diabetes. We've shown that the DEFEND study, which was run in Auckland and South Auckland, showed that a case management approach was effective at improving blood pressure and improving diabetic I'd echo control. David's comment that
in the DEFEND study and other studies, obviously glucose control, diabetes control includes the glucose, the blood pressure, the blood fats like cholesterol, but also education around foot management. Many of those renal patients, those kidney patients, they have vascular disease and nerve damage to their feet, so they are more likely to have amputations as well. But many other patients who maybe do not have kidney disease also have a risk of when you're providing the standard primary care. So, case management and nurse support between appointments, and as many strategies as we can. You just got to tailor it to those individuals so that we can turn around the terrible harm that's being done.
Matiri here, just a question to Janet around, you talk about the fact it would be great to have better access to some of these medications in Aotearoa for Māori and Pacific people.
So,
what do we need to do? Experience with the SMART study in asthma, doing clinical trials specifically with Māori and Pacific people and being able to show the funders just a question to Janet around, you talk about the fact just as, if not more effective, to some of these medications did go some way to persuade them to fund that. What do you think needs to happen?
Look, I think there's been a push from a number of diabetes specialists to increase access to these drugs. The evidence would suggest that irrespective of your kidney function, irrespective of your ethnicity, that a number of these studies included African Americans. The Credence study enrolled patients from Australia and New Zealand, however, in very small numbers, probably inadequate to comment on specific Pacific subgroups, that there was benefit. And, I think it would be hard to say that anybody wouldn't gain benefit from these drugs, given that the evidence is out there. And I think Pharmac should really be convinced by the literature without us having to kind of replicate the wheel.
Question for both of you. How do we change perceptions that diabetes is a self-created problem for people? This is a question from Paul.
I think that's a very big question. And I think the fact that we now can show the diabetes remission when people are supported shows that these changes can be made. I think it shows the level of support that's needed. I think we have enough evidence from twin studies, from so many studies around the world, that this is about genetics and endocrinology, obviously in the social setting. And we need to show and we need to invest in how we support people. But around that is obviously the social marketing and trying to get through to people that this is very much the people making comments about why don't they get on a bike. Often that's because that's what they do. And they're trying to say, look, I do it, why can't you? They need to understand that there is great differences, heterogeneity, there's variation in people, and things are actually under genetic control. There are so many studies now, but we need to have an active campaign to balance the need that people do need to also decide to make changes in their lives, but also understand that that needs support. And that's a very, if you listen, that's a very complicated message. And as in, you know, as I said before, it is complex, and I don't think any country has quite got it right, but it needs to, we need to have that kind of social marketing, that people realize that if you blame people, it doesn't help. And in fact, many of those individuals who are larger, they have a multiple number of reasons why they are the way that they are. And we need to understand that. And we can't just say, look, it's all your own fault, when we actually know from the studies that it's usually not.
I think, David, we've had, I mean, a similar experience here in South Auckland with COVID-19 recently. I'm not sure if you've been aware of it in Australia, but I think it's easier said than done, and it certainly needs more attention.
I think it needs investment for that attention, and it needs to be properly organised and coordinated. But as I said, it is difficult because we don't know how to project this message globally, and yet we have so much data around it. You know, it's pretty clear if you have two twins and one is in one setting and one is another, and essentially they both end up roughly the same, that's pretty clear that this is about genetics, but somehow that message is not getting through. I think in terms of the COVID-19 message, then again, that is also complicated, but perhaps as a shorter timeline. We've been dealing with this now for decades, and we've known this information for decades. Why is it taking so long? And I think that has to be one of the questions. I think, you know, people have tried, but perhaps we need to comprehensively look at this. And I think that Counties Manukau, South Auckland is the place to invest and say, this is the area where these numbers are going up so much. Where, as I understand it, dialysis units are now having to be built in the community because there are so many people needing dialysis. This is unheard of. What is it going to take to people to realize this needs to change now? Very simple.
That's obviously inviting a response from you, Janet.
Yeah, look, I think there's a lot of stigma around diabetes, and you know, I think we all want to say, look at someone, it's those people rather than us. And I don't think anyone is suggesting that that lifestyle changes aren't part of the management of diabetes. There is stigma associated with it, but I think also it's important to highlight that some of the medications and therapies that we use have side effects which make them undesirable, specifically weight gain, specifically hypoglycemia, specifically GI intolerance. And many of the newer medications that are available elsewhere prevent those complications, allowing greater tolerability and better glycemic control.
There is a question here from Angela, and so we've heard David and Yannick both make a case for new diabetes medications. The question from Angela is, where do you think the role sits with lobbying Pharmac?
Where does the role?
Yes, whose role is it?
Well,
can I jump in there?
Yeah, please do.
I know the diabetes. I know that specifically Rinky Murphy, who I think asked the question before, brought together a group of diabetologists and other interested specialists and put a case to Pharmac. However, it's important to recognise that Pharmac have a limited budget, and that budget is controlled by the politicians.
So Janak, is that the answer?
Well, it's maybe an opportunity for other people online to speak.
I think that there's always a difficulty in moving the enormous amounts of money spent upon hospital services such as dialysis and so forth into the preventative approaches, which may be medication, it may be people, it may be investment in access to healthier foods, the cost of healthier foods. So there's often a very big difficulty in moving that over, but it's something where you have to invest in the future. And there are models of those around the world. There are insurance companies that will pay up front for the support for these kind of preventative approaches because they know it's going to be cheaper downstream. And therefore, perhaps there needs to be that investment fund for prevention, which includes preventing complications in those with diabetes. So, you know, I think that while we say there's a limited budget, actually that's because it's being eaten up by other things. We're not refusing dialysis. Some people refuse it themselves. And that was an issue when, interesting in the ACE inhibitors, those new drugs came out that you spoke about, Janak, that North Health, as it was saying, look, you have to decide who you don't give dialysis to. I was there in South Auckland at the time. That's not going to happen. So we're not going to stop that spending. So we have to pay up front to prevent that expenditure downstream. And we invest in these kinds of activities now.
Thank you, David. There's a really good question here from Jade, which I'd like to direct to both of you. Diabetes treatments are less prescribed in Marion Pacific. How do we ensure pharmac funding of new meds gets to these communities? It's a really good question.
I don't know, Janak, do you want to answer or shall I?
Well, look, I think that's a great question because I think equity is not the same as equality. And, you know, I think sometimes you have to give people a boost to try and achieve better therapies. The data that David's presented, the data that I present really highlights that Maori and Pacific communities are disadvantaged and not, and probably not achieving equitable access. One thing that really gets up my nose is the prescription fee. That I know that in January, February, when I prescribe medications, there are a number of patients who will not be able to access their the number of medications until later in the year because of the prescription charges. So whether there's a waiving of those, I think it does relate to healthcare being moved from tertiary care into primary care and widening the accessibility of primary care for disadvantaged families.
So in fact, thanks, Janak. In fact, in the Diabetes Care Support Service data, we found that there was no difference in the attendance at primary care. There's obviously this difference for specialist care, but it's so little anyway that if anything, it needs, I would say, needs to be more for those that need it. I think the issue is that people actually need support in the community for using the medications, for example. But I also think primary care needs access to the tools and to have the knowledge about the newer drugs, and they need support for that. It's a global issue. I think the issue around the cost of drugs, many countries do provide these medications to those with diabetes at no cost for the reason that it is an investment in those individuals. And if those who are of lower socioeconomic status are those at greatest risk, then clearly they're the ones with the greatest barriers as well if they can't afford those medications. So I think there's a very clear indication and evidence around the world that that is what should happen. Those with diabetes should not have to pay for their medications because it's a preventative treatment, and diabetes is largely asymptomatic. People don't feel bad. Sometimes they feel worse with their medications, especially the older medications. So it's certainly something which doesn't drive people to want to take, you know, pain relievers or these other things because they feel bad. So again, it's a very complex set of things that stops people from taking the medications, but they do need to have it prescribed. And in fact, people are accessing primary care. We know that from the blood pressure equivalents. It's the fact that the glucose control is more complex and primary care needs that support. And around the world, it's happened by advisory lines and through online support and through people coming in who are specialists and talking with them. So, you know, primary care is the front line, absolutely, but they need support and that can be provided.
Thank you, David. There's a really good question here from Kim, probably for you, Janet. What are the ways we can show Pharmac that investing in these new drugs will reduce our healthcare costs in regards to opening up new community dialysis centres? How do we get that proof?
Look, the cost of 1 year of renal replacement therapy is approximately $90,000 for someone who has centre hemodialysis. It's probably about $60,000 to $70,000 for a satellite hemodialysis, and about $45,000 to $50,000 for someone who does peritoneal dialysis at home. Now, I think the evidence is out there to say that therapy with canagliflozin used in the Credence study delayed progression to kidney failure by 15 years. So I would have thought that the evidence is there for Pharmac based on the literature that's available.
Excellent answer, Janet. I've got a question here again from Rinky. Once funded, do you think that direct consumer marketing will increase SGLT2 inhibitor use amongst people who need them? Just a side comment, I think it was Rinky's experience from the Worth study that the uptake of vildagliptin in different practices across the country, there was a high level of variability. So I think that's a question for you, David, mainly. Direct-to-consumer marketing and its role.
I think the direct-to-consumer marketing depends to some extent on people's ability to pay. I think it depends on their health literacy. I think it depends on the support around them. And again, it may be that those with the greatest need are those who don't benefit. So I'd rather see a systematic, organized, coordinated approach to make sure that those who need it receive it, that we have a monitoring approach of clinical practice. And if someone who's at high need has not, and we can, I mean, there are systems that do this already around the world. There's certainly those that I've seen in different countries where you put the prompt to the GP and information to the patient through the GP that says, look, this is someone who's got this particular HbA1c, this is a threshold at which they should be having an additional agent. So I'd rather to see coordinated, organized, integrated healthcare rather than a sort of a free-for-all scramble where they advertise. I think advertising may increase people's awareness, and I don't think it's necessarily harmful, but I don't think in any way we should depend that for those who have the greatest need and who are actually often the ones who end up on the dialysis.
Thank you, David. There is another question here from Natalie. And there's another drug that's used overseas, not available in New Zealand also. How much difference do you think extended release metformin would make to adherence and reduced HbA1c in the New Zealand population?
I think extended release metformin is useful for those 20% or so that can't tolerate metformin itself. And so it is beneficial for those reasons. The second issue around it is as a once-a-day dose, it means that people are more likely to take all of their tablets instead of only part of them. So it improves the effectiveness of the medication. So, I mean, there's clear evidence that once-a-day medications promote adherence more than multiple times a day. So I think it's a useful tool for those individuals. So that's just one of several tools to help people with their adherence, and for those with the side effects, it will help those 10 to 20%. There are still those who even are intolerant on extended release, but it certainly helps another 10 to 15%. And metformin is a very useful, good medication that's weight neutral, and for most people doesn't have side effects. So it's very useful, and it's a shame if, and unfortunately, if people cannot take it.
There's another question here which might be a little bit hard answer, but again from Elaine, what is the yearly cost of these medications compared to dialysis, which is in the tens of thousands, please? And of course, we're talking about country to country differences in costs. And also, Pharmac has its own inimitable way of doing business and gets drugs for much lower cost. But any thoughts on that, David or Janet? Yearly cost of these drugs?
I think I was at a Pharmac meeting which suggested that the cost of these, well, no, actually, Rinky might actually know the answer to this.
Yes, I don't think Rinky can speak to us, unfortunately, Janet.
So if I can just say, in the UK, the NICE, as many people will know, have a very well organised and thorough approach to medications. We don't always agree with them, but they link the cost of medications not only with the reduction in downstream costs, but also the quality of life, which, as far as I understand it, is not something which is quite as robust with Pharmac in its analyses. And as a result of that analysis, NICE was an early adopter of these medications. So those kinds of assessments are made in different countries, and that's why around the OECD they are invested in, because they are cost saving long term. And sometimes you just have to have a range of these kinds of approaches to have an impact on an epidemic the size of ours. And unfortunately, as we showed, South Auckland is a hotspot and is where the greatest investment is needed. And these medications are particularly important in our area, but obviously for anyone with these high glucoses around the country.
Thank you, David. Well, I'd like to thank both of our speakers for those really excellent presentations, and to people who contributed questions for what I think was a really robust discussion. I think it's probably time now to move to the second part of our program, and to welcome the 4 politicians who've given up their time to come along and speak to us this evening. I'm thinking I've done a lot of talking, and at this stage I should probably hand the chair over to my co-chair, Dr. Materi Harwood, and let her introduce the second part of the program.
Kia ora. Well, it's with much pleasure that we invite our next group of speakers to give their perspectives and that of their parties, I guess, to this major issue that we've just heard about this evening. I would like perhaps for each of them to introduce themselves and then perhaps talk to your own personal experience of diabetes in South Auckland, or that of your whānau, and then a few more minutes on some of the issues that have been raised here, on how if you were to get into Parliament, starting from after the election, what would be 3 or 4 things that your party would do to address diabetes in South Auckland moving forward? I think we would all like to hear that. So if that's okay, I might start with the youngest of our rōpū. I'm not sure if I'm going to say this properly. Is it Lord?
It's Lourdes, but that's okay.
Lourdes Vano from the Green Party. So thank you, Lourdes. So we've given each of our speakers 5 minutes.
Awesome. Well, thank you so much for having me. My name is Lourdes Vano. I am the Green Party candidate for Manurewa. My family is from the Cook Islands, from Samoa, and my dad's part of the family is also from Ngāti Kahungunu ki te Wairua. So I am both Māori and Pacifica, and diabetes is very prevalent in my communities, and especially in South Auckland. I have several family members with diabetes, and I've seen firsthand how inaccessible a lot of these things are. And I've been taking notes all evening. I'm really thankful for all of the additional information you've given me about the background and about the inaccessibility of medication in particular. And I've got the most recent manifesto for the Green Party in front of me, it talks a lot about getting to the root of the problem, finding out why it's more likely to be Māori and Pacifica who are disproportionately affected by not only diabetes, but a lot of the diseases you've been talking about, and beyond that, and figuring out what adds and makes these situations worse for people. For example, food security and accessibility are two of the major things that we're focusing on. And I'll read something out that we've written in our health section, which is page 22 if anyone's got it. But it's ensuring everyone can access healthcare services regardless of their ability to pay at the earliest stage possible. This includes working towards providing adequate funding for community-based care. Like you were saying, there are dialysis centres all throughout the community, and we need to be holding people like Pharmac and like our politicians, and hopefully if I get in one day, I would be held to the same level of accountability, that we need to be fighting for these people who are disproportionately affected, and increase accessibility to a lot of these things, as well as increasing food security. These are a lot of the things that our MPs have been pushing for, and will continue to push for if we get in again into government. But yeah, we just need to, we really need to bring the focus back to South Auckland, because like Dr. Matire, I think your name is, brought up before, the COVID-19 has also disproportionately hit these communities, and we just need to be very mindful about, like Professor or Lecturer Yanak was saying, what's it called? Equity is not the same as equality, and improving accessibility, particularly for the people who really need it. I feel like I've been talking for a while, so I'll pass it on, but I'm happy to answer any questions later on. But yeah, thank you for giving me your time and having me today.
Thank you so much. It was nice and short and to the point, and yeah, some good points raised there. So please, Whānau, keep sending through those questions, and I'm sure each and every one of our guest speakers in this next section will be happy to answer them. I might now move to Mote, who was the first person to arrive at our session this evening. Is that all right for you to speak to us now, Mote? We'll need to unmute you.
We'd like to thank the Diabetes Foundation Aotearoa for inviting me to be involved in this forum. Thank you, David Simmons and Janik and John Baker, for all your hard work through this disease. Listen, I can't stress enough how devastating this disease is, and it has wreaked havoc out in our population in South Auckland. So I'm a wee bit intimidated by all the statistics that I've seen, but what I can get out of all that is South Auckland as a hotspot of diabetes. And our population, specifically Māori and Pacific Islanders, are the hardest hit. And if we look outside, globally outside New Zealand, it's absolutely frightening. And out here in Aotearoa, I guess we can say South Auckland, it's a death sentence. All those people from the Pacific Islands, if you can have a look throughout the South Auckland suburbs, Pacific Islanders are really, really obese and overweight. And I am a candidate for the new Conservative Party here in Manurewa. And we've got two words to solve this problem, diet and exercise. And I think that's what we lacked most in the Pacific Islanders. We've concentrated too much on a lot of other things, but we disregard what we need to do. The health experts, the DHBs, they can only do so much, but we need to do our bit. And if you have a look around, we haven't done very much at all. And the New Conservatives, we're going to pour in a lot of funding to the diet area. If you see overseas, there's a number of countries have taken GST off their food that are really good for our health, vegetable and fruits, no GSTs. And we need to put a lot of funding into that. And food choice. There are always conflicts between the private responsibilities of the Pacific Island people and the actual public responsibilities. And the private responsibilities is how we choose the food that we eat. And mainly the parents choose the food that we eat. And usually the authorities do not want to intervene because our relationship with our culture and our religion. And I think we need to be a lot harder on that. That we need to put in good advice, good experts, and advise people with their diet. And exercise, we've also put a lot of funding into exercise. And we have to start very early at school. At school, we need to start early, and that makes that a part of the curriculum. And living healthy, and make sure that young kids have an input to their diet at home. We also want to, the government fund health checks to enable early intervention in common health issues. And this disease, diabetes, is really, really number one in our priority. And we need to have a lot of input into that. I think our community is our biggest gathering spot is our churches. And I've noticed, I think David Simmons mentioned in Sydney that they may have used the church to try and improve their diet and a lot of exercises. And I think here in Aotearoa, we're a bit soft in the way we enforce these two issues. And the churches need to have a lot more input into this too. The churches need to maybe cancel a lot of their churches services and try and spend a lot more exercises and a lot more advice given to them on diet. And food is always a big focus on the Pacific Island meetings, Pacific Island services, weddings, everything. Food is number one. So it's very easy for Pacific Islanders to cut that in half and help reduce their weight and obesity in order to help the medical experts in trying to control this disease. A lot of issues mentioned that maybe funding for the services be moved to preventative measures. I really agree with that. We need to not only wait till we get to the dialysis stage, but we need to prevent dialysis happening by starting from the beginning. So I'm all agree with what the experts, the two experts, Janik and David have mentioned. Pacific Islanders need to wake up now and do something for themselves. There's no point of getting the expert and the medical people, pharmac, to spend a lot of money trying to cure our diseases, but we're not helping ourselves. So from the New Conservative point of view, diet and exercise, we're going to put a lot of funding into that if we do get into Parliament. Thank you.
Thank you, Moti. We might now move to Agnes, who is standing for the National Party here in South Auckland. Thank you, Agnes.
Right, am I unmuted?
Yes.
Great. Good evening, everybody. Tēnā koutou katoa, talofa lava. Thank you very much for this this wonderful summit. It's been thoroughly engaging, and thank you also to Janek and David. Fantastic, presentations this evening. Grim as they are, it's great to have that fantastic insight into it. Just a bit of background on me. I'm the National List MP, and I'm also the candidate for Māngere for 2020. I'm of Samoan heritage, born and raised in Auckland. I'm also married to Ward Kamu, who's Māori, so we don't feel that we've given our 5 children, possibly the best genetic start in many ways if we consider the information that we have all seen this evening. Nonetheless, it is something that I know intimately, as with Lourdes and Morte who have spoken. We have people in our families that have diabetes, are living with diabetes, and also, sadly, we've lost family members to diabetes. So although I am new to the health portfolio, I've just come in as associate spokesperson for health really in the last month under our new health spokesperson, Shane Rishi. And actually, forgive me, I do also bring apologies from Dr. Shane Rishi, who would have loved to have been present at this summit, but he couldn't make it today. So unfortunately you have me, but I am particularly pleased that I have come on tonight, because it's an area that's close to me, as given the number of people in my life that have been affected, but also as a parent of Māori Samoan children, raising our 5 children. How do we reconcile as Pacifica and Māori the culture that we come from, very strong cultural backgrounds, with this this pandemic that we are actually genetically predisposed to, and it's something that hasn't been easy. And just tonight, my husband has taken our younger children out for a run, and for a bit of exercise. It is not easy, and it's a challenging space to be in when we love our culture, we love the way that we've been raised in our culture and tradition, but also conscious that we have to manage the situation for our children in terms of the health space. And I'm particularly keen on dealing with healthy eating for our young people, because it's not just diabetes. I'm also very passionate in the area of dental caries for our young people, which also affects disproportionately our Māori Pacifica children. So healthy eating is something that I try and promote as much as possible, because of the long-term health effects, not just with diabetes, but other health, those dental issues that can occur as well. So very, very passionate in this space. I'll just give an overview of our National Party position on diabetes. We are about to release our health policies. I won't be the person doing that, but they'll be released more specifically by either Dr. Shane Rishi or our leader, Judith Collins. An overview is that, we understand the importance of prevention. And so in government, we did some work in terms of promoting healthy eating guidelines, the child obesity plan, health star rating system, and we will be looking to expand work in that space. And so it was good to note, I think it was David, that work that was done in the Waikato area. So it's an area that was piloted, but we'll be looking to expand that definitely. There was, in terms of pharmaceutical management, National, we will be putting more money into Pharmac in a sustainable manner that gives some surety. I can't give some numbers, but this will be of benefit to diabetic patients. And there's been definitely talk, and as I've said, given my own genetic background, in terms of the inequality burden that diabetes places on Māori and Pacifica. So the policies will be framed with that inequality lens to address these issues. And I was particularly interested, David, on the information that you gave around counties Manukau and the lack of access to those specialist services and to the drugs. So I will be looking to follow up with you more if I could just get that information again. I'll leave it there, but very happy to have questions. Thank you.
Thank you, Agnes. And for our final speaker, we have John Tamahere from the Māori Party. Welcome, John.
Yes, kia ora matiri. O he arawa kia koe tō whakamuimiti te runga rawa ki te tīmata taimu hui. He arawa kia koe tō mihi mana kia mātou. An kai wari kia mātou tō mahi rangatira kei te awhi arihi manaki ina iwi whānui. Ko te tunga mata kia koutou, tātou tungora kia tātou. Just wanted to acknowledge you, Martidia, for your kind words in opening the meeting. I'll be reasonably concise. You're very impressive, Lords, and if I was in Manurewa, I'd vote for you without any disrespect to Moti. I just think you're outstanding for a young person. So good on you. Good on you for standing up. We already have. I'm talking about Māori. Already have a statutory framework that obliges the Crown to work with us. The fact that it lays dormant on the statute books and plays out through DHBs and MOH is a statement about the way in which racism and discrimination continues to work in our system, and that's just a disgrace, and it just needs to be sorted. And because if white folk were in the same difficulty that we have, I can assure you that metformin XR, that the SGLT2 inhibitors, that the GLP-1 agonists would all have been funded. It's only when when brown folk have to live in overcrowded dwellings and live in cars and vans, it's okay. But we have a housing crisis when it shifts to non-Māori. So we need to have a grown-up conversation about the way in which we are consistently embedded structurally at the bottom end of town. A Māori health provider is funded 20% less than Pākehā. That's just not right. That's just unacceptable conduct. So that's the first point I'd make. The second one, if I could just hone in on diabetes, my father, it's not a blame game. There is a good book that says, forgive them for they know not what they do, when people either criticize or alternatively tip into morbidities. So I don't get into a blame game, because I know that our people are better than that and didn't overtly and wake up one morning and say, no, I'm gonna contract type 2 diabetes through my lifestyle. So of course, therefore public health requirements have to be lifted and targeted. And there are the walking Samoans, and there are the walking Tongans, and there are the Iron Māori groups out there, and they do a marvelous job. There is Butterbeans Academy out there. There are opportunities. They are not supported in terms of the type of public health services that they conduct well. All the money goes to non-Māori and Pacific Island peoples in that regard. That has to change. So we have to target that. In terms of the health workforce, we are strong believers in the Māori Party of a greater devolution to allied functionaries, for the want of a better way to put it. In other words, we believe that nurse practitioners and paramedics fully trained can play a significant role, and it does not always have to end with a magical GP at the end of the line. Does not have to. And COVID wave 1 showed us a dramatic load that our nurses carry in primary health and also in testing stations and the like. They carry the burden. They're underpaid and they're overwhelmed, and they need to be honoured with a greater level of devolution of authority and power commensurate with their experience and their undoubted capacity. So that's where we would be looking to increase cover and reach. In terms of health portals and the digital world, that can play a significant role here too. I'll give you an example. We own and run the company that drives e-prescriptions in this country. Pre-COVID, 21% of GPs used e-prescription. In COVID, 84%. Post-COVID, in the 100 days between the transmission, they went back to a 200-year-old system, of a choke point around GP practices, and that makes it very difficult for us. Just two last points. On pharmaceuticals, I've made my point known at the commencement of this, that the South Auckland study is beyond reproach. The outstanding lobbying work by Dr. John Baker is a tribute to the Diabetes Foundation Aotearoa. I just wanted to acknowledge you, John. Of course, Yannick and Dave, you play a significant role, but you're talking to the converted here, and your evidence is just spellbounding. It's demanding of attention and demanding of funding. There's no counter. You see, there's no counter evidence to it. No one would have the kahunas to do that. And then I would finally finalize this by saying that there has to be a consistent approach to continued funding to areas like this. You know, and when it's screaming out that our Pacific Island and Māori peoples are in terrible disarray in certain areas of health and in certain areas of education and certain areas of welfare, certain areas of housing, it demands a response from the government, okay, and not just lovely platitudes. And so this rejuvenized and re-energized Māori Party is just the start of a new Māori movement, political movement, and my children and my grandchildren have been bequeathed to it, like my grandfather bequeathed us to the Labour movement. I'm very happy to be a liberated native tonight. Kia ora.
Kia ora, John. Thank you, all of you. I think that was a great start, and I can see that there are some questions coming up, but my eyesight is not great tonight, so I'm going to let John Baker address those. But before we start the questions coming in, I thought I'd ask you all to perhaps respond to one thing, and it is this question of acute versus chronic, and we've seen a huge shift in models of care and the response of the health system to COVID as the crisis, as a pandemic. But as David says, you know, the biggest pandemic facing us in South Auckland is diabetes. How do we balance that acute response to something? And if you were to put something in place tomorrow, as we've seen has been done with COVID, what would you do tomorrow to make a difference? And perhaps I might go and start in a different order and start with you, Moti.
Yeah, the diabetes is chronic throughout the world, and in New Zealand, especially in South Auckland. And I think the funding with regards to this diabetes with this disease has to increase. If you have a look at the COVID-19 versus diabetes, the differences is huge. The death from diabetes is big versus the death from COVID-19, and we've stopped everything on COVID-19, and when we've lost interest on the other diseases. And I think there's a need to differentiate between this disease, which is really a death sentence to South Auckland people.
Thank you. Agnes.
A good question. I think one thing. Well, I mean, I think as David has highlighted, it's not one way to address diabetes. It's complex and multifaceted. But particularly of interest to me was the concept around social marketing. As we now know, everybody in South Auckland is has known in a short period of time, knows about COVID. And yet, you know, diabetes has been, you know, the most pressing issue, health issue for us in South Auckland for a long, long time. And yet it doesn't actually rate up there in our psyche like COVID does today. And so I think it would be actually, amongst other things, is to start a social marketing campaign, very similar to how COVID has been relayed out to the community daily on every feed, everything possible, raising the awareness that actually this is actually preventable, and particularly mindful of the increasing relevance of diabetes on our young people. The numbers are staggering, and I'm particularly mindful of our young ones who are. We've got high rates of obesity for young people in South Auckland, and so actually it would be a social marketing campaign to get that awareness out there, to let people know that this is just as important, if not more so, than what we are facing currently with COVID.
John Tamahiri, your response.
Look, you just have to go to our communities. Moti indicated the churches. That's wherever we have organisational hubs where our people are engaged and our people are trusting, and where there's a wraparound opportunity and capacity for them, those organisations just have to be funded. So we've got a lot of third-party organisations that are funded on our behalf and do a good business at managing our failure. But there's not enough accountability in terms of, if dollars are put into a service, the extent to which that service works for Māori and Pacific Island people. Okay, for a whole range of reasons, which because I'm painting in broad brushes tonight, but for a whole range of reasons, non-Māori white folk do better for a whole range of reasons. So because Māori and Pacific Island peoples don't have a large middle class to drag them through, it then disposes us to look at, well, who can get the best bang for buck in regard to public messaging around better lifestyles and so on. Who can get the best bang for buck in regard to wrapping around the difficult mental health issues that arise when you are carrying morbidities like this? Who is the best? Well, it definitely isn't a clinic-led service. GP services, nurse-led services play a very important role. But unless there's got to be a start and an end to where they are, and that is out in our communities. You know, and we are now skilled enough, good enough to be invested in, to actually start to lift the capacity and capability of our own communities to start to look after our own issues, rather than thinking that we should always bow our head and hand over our livelihoods to somebody else that drives away in a better car to a better part of town. Or with all due respect to the good people from the foundation.
Thanks, John. Lourdes.
Yeah, well, just to reiterate a lot of what the other candidates and MPs have said, it's all about education. Like David was saying earlier tonight, all of the information is there, all of the data is there. We need things perhaps in high schools, perhaps in primary schools, about better lifestyles, and also a social media marketing campaign. But if I was to, I think the question was to, like, what would I enact if I could enact anything tomorrow? And the thing that really stood out to me from the presentations that we got earlier this evening was special services investment and putting time into these communities and meeting people where they are, like John Tamahiri was just saying, getting buy-in from the community on why this is important, education on why this is important, because like everyone has been saying, it's a very old, well, not old, but it's been a very prevalent issue in these communities for a very long time. Raising these issues, getting people aware, like everyone has already said, and really, really pushing for investment into these places and giving money to the appropriate foundations and the appropriate associations that are really going to look after these communities and recognise which communities need help the most. Just to reiterate again, the differences between equality and equity, and making sure the people who need help get the help first.
Good Lord, as all of you were speaking, I couldn't help but thinking, do we need a Māori or Pacific Ashley Bloomfield doing an announcement at 1 o'clock every day about diabetes and what's happening in South Auckland? But that's just my idea, so don't steal it, anybody. I might leave it over to John now because, as I said, I can't read the questions that are coming in, and I'm sure there are some fabulous ones. Is that all right for you, John, to take over now?
Yes, thank you, Materi. Something that David alluded to in his talk, something that's a very great concern, is increasing rates of type 2 diabetes in young people, and I'm talking about adolescents and even small children. So type 2 diabetes, when I started my diabetes practice 40 years ago, used to be called maturity onset diabetes, because we never saw it in people aged less than 40. And over the years, we've started to see it in progressively younger and younger people. And I think this is a big concern because the devastating complications of diabetes that we all know about are a consequence of how long you have the condition. When you get at a young age, it means you're going to get the complications at a younger age. And that's a very big concern, as Yannick has outlined. So what I'd like to ask each of the candidates in turn, if I may please, what particular strategies do you think you could put in place to deal with this particular problem that's diabetes diagnosed at a young age in young people? How can we protect them? So I might follow Materi's example, but turn it around the other way and start with John Tamahiri, please.
Sure. Well, that is a simple question desiring a very complex answer. The first, so it will require a package of things. One issue is around nutrition and the ability to use limited dollars. So you're talking about a community where 78% earn under $50,000 a year, $50,000 a year. 1/3 of them also will be on welfare of some sort. Our people don't eat 2-minute noodles and put them in their trundlers because they want to. It's an issue of poverty. So once again, it's not a blame game. You with me? It's a poverty. It's a poverty trap. And so a lot of our issues are just in regard to being poor. You know, 60% of our prisons are Māori in terms of women, full of 60% of our women, right? But 80% of them are there for crimes of dishonesty. That's not, they don't wake up to be dishonest. They wake up there to put kai on the table, and they wake up to, so it's crimes of poverty, and it's a criminal punishment system, not a justice system. So if you understand where we're embedded structurally in society, and we need significant policy shifts to shift us out. Māori Party's already presented some of those. We then have to acknowledge that there is a different way of communicating with these communities, okay? And the sexy, fashionable ads and all that stuff run by the Ministry of Health on different things, like, you know, brushing our teeth. You get the old fat Polynesian fairy come into the room, you know, because only our kids can have terrible teeth. So I don't like that negative advertising. I don't know who the hell buys it. So we need champions in of ourselves, to ourselves, talking to ourselves, that have lived experience, and they're real people, you know. See, like Butterbean, he's a real person. He's through his own capacity, and it dropped kilograms and kilograms and changed his whole lifestyle for the better, and had a massive impact on a lot of people. I'm only using him as one example. So to answer your question, it's extraordinarily important that in our own communities, we have our own champions that advance our interests and our own ambassadors, and they're there, and they're very noble people. They just get locked out of any resourcing whatsoever. And so my biggest issue is getting health and nutrition messaging across to our people, but not in a regulatory standover way, but in a more caring way, that we understand you, we've been on the journey, and here's where we are, right? So don't take a stick to this. It requires lots more carrots.
Thank you, John. I might ask the same question to Moti, please. So the question is, Moti, what strategies would the new Conservative Party have to help our young people who are the most vulnerable and the most likely to suffer harm from this devastating condition?
Thank you. You're absolutely right. The younger generations are slowly catching the disease, and I think it's all started from home. I mentioned earlier about the private responsibilities that the parents get to choose the diet that they have at home, and the children participate, and whatever the parents choose. Of course, the parents have already got diabetes, and the children will follow. And I just reiterate what John mentioned about the diet and exercise. And I think we need to have a lot more of butter beans throughout Auckland. I reckon every church should have a butter bean to rope in all the member of the congregation to participate in diet advice and exercise. You know, this disease have a huge relationship with the explosion of the international fast food corporations, the KFC and McDonald's, and South Auckland. I think the government need to rope in these big corporations to have an input in fighting this disease. And I remember I was with KFC a long time ago. I was working in their office, and the biggest seller of the big buckets is the KFC in Mingri, and they always top the country in terms of money coming in and the meals going out, big meals very early in the morning for people of Mingri. So I think there needs to be some tax or some contribution from these huge corporations to help the people that push their income up over the roof. So diet and exercise is vital, and we need to do that at home at the beginning. Now, I mentioned earlier about the schools, that we need to have these in the curriculum, the importance of early intervention and personal responsibility for their health. And I reckon that the children need to have an input to the type of food that they eat at home. Thank you.
I'm going to direct this question now to Agnes. Agnes, what can the National Party do if they win the next election to help our young people? So people with diabetes, but also the children that do not have diabetes, but that are at risk. And you heard David talking about the allied problem of obesity in our community. What will the National Party do?
I think we'd be expanding what we did in government, which is around healthy eating guidelines. And also there was a pilot which was called, I think it was called the Daily Mile, it was just simply getting kids in schools to run for 15 minutes a day. And I think there was maybe 14 schools that were part of that pilot, and expanding some, whatever you call it, is about activity and ensuring that we are getting some education around healthy eating. But I think I'd echo what's been said tonight around, there are a lot of community organisations that are actually already doing this in the community. It's sometimes ad hoc because they're not supported or they're not funded in any way. But actually, it's one thing to teach good, healthy eating habits to children in schools. That's got to be also carried on in the home. So I know there are organisations that actually support families, and there are some organisations that provide events where they actually support the child and the parents to do some fun events like gearing up to do half marathon. So if you can support the whole family into, teach them how to sort of eat more healthily, but also create an environment where they can do things together, where there is activity, where it benefits the parents and the children. Of course, the other mutual benefit is actually kids love doing things with their parents, and they're not probably getting enough of that these days. So anything in that space, I think we should be supporting.
Thank you, Agnes. I'd like to address this question finally to Lourdes. You've heard the other candidates talking about this. So what are your views on this, and how would the Green Party help here?
Yeah, well, I want to build on a lot of the things that they've been saying about educating kids, and supporting a lot of associations like Agnes just mentioned that are already doing a lot of this work, and funding them and getting them the money that they need to support these families. But as well as that, the education is nothing if people can't actually afford any of the food, and the Green Party acknowledges is that we need to have accessible food, accessible healthy food, and accessible education to what is good for you and what isn't. As well as that, I just want to build off what Matire was saying before, about having our own Dr. Ashley Bloomfield. Similarly to that, it's about funding our own people and our own academics and our own professionals who know what it's like for Pacifica people and for Māori people to go through these hardships, who can educate them, like Dr. Ashley Bloomfield has been doing for the entire country, but in particular for people of Pacifica and Māori descent, so that we can start acknowledging these problems to the very root that they are, instead of doing a very blanket view, which won't always work, and it hasn't been working for a very long time. And another example of how we can do that in other spaces is, I'm reading again from our manifesto, incorporate mātauranga Māori into the health system and fund provision of primary healthcare through Māori organisations, overseen by a new Māori health agency that focuses on remote areas with significant health disparities. So a lot of what the Green Party is about is getting to the very root of the problem. Why are younger people picking it up, and why has it gone decreasingly down in the past few years, and identifying those problems and addressing them in a way that meets people where they are, like John Tamahere was saying before, and getting that buy-in from the community.
Thank you, Lourdes. That's a really excellent answer, if I might say so. I've got one kind of last question. I think we're probably reaching the end of our session. And it sort of crosses back to the work that Matire has done with the Papakura Marae practice. So the question was from one of our listeners: how can we make it easier for patients to visit their primary care team? And so there are some specific Maori providers in South Auckland, and also Pacific providers. And I think they do a fantastic job. They see 85% of the patients with type 2 diabetes, and David probably would say that they should see 100% of the patients with type 2 diabetes. How can we help them with prescription charges, doctor's appointment charges, podiatrists, dietitians? They do the heavy lifting. How can we make it easier? So I might just mix it up and ask Agnes to address this question first. How can we support primary care better?
I mean, this is an excellent question, because actually this is, I read reports that actually Pacifica still are low in terms of our access to primary healthcare as a proportion. And so we have to understand what are the barriers. One of the ones that comes across to me is actually, our Pacific communities are often, in terms of the employment situation, they're in roles where it doesn't actually fit in. The hours that are available for them to access GP services don't fit in with either their shift work hours or care arrangements with children or elderly parents they're taking care of. And so, of course, we do have quite high numbers of our Pacific people who are going straight to the hospital and bypassing GP services. So we've got to look at how that could be better designed to fit in with our lifestyles and sort of those shift work hours and also the challenges in terms of, sometimes just transport. It is also acknowledged in, and I know this, with Pacific families, is that we're more likely to put off seeing, a GP until it's really serious, and so it's sort of going late, and therefore that challenge of care, which could have been seen to a lot earlier. So definitely, how can we get that across to our communities to actually, get promptly seen, particularly if you are the carers in your family and you put yourself last, is actually you tend to put your issues aside and care for everybody else around you. Definitely needs to look at how we can better get support for funding in terms of the, I guess the prescriptions, and that is one that comes through a lot in terms of what is it's a wee bit. The model at the moment is a bit rough, and so we need to know how we can actually ensure that those who are most in need can get better support in terms of the cost of prescriptions. That is one that comes across to me in my office as well.
Thank you, Agnes. Moti, would you like to tackle that question, please? Support of primary care and particularly Marion Pacific providers.
Yeah, thank you, John. Primary care access, I think the biggest barrier with Pacific Island and Māori is the actual charges that the doctors have initially, and the prescriptions charges, and of course language comes into it. But I think there should be some system where if you've got diabetes and you have ongoing treatment and you need to see your doctor for tests every 2 months, they need to have a system where if you've improved your weight or improve your diet or improve your blood pressure, there should be some way of rewarding you for the improvement that you've made. And that should reflect on the fees that you pay for a doctor. Say, instead of paying $18, you pay $10 if you've lost 2 kilos, something like that. And of course, language is a big barrier also. For older Pacific Islanders, they tend to stay away from the doctor and wait for maybe the son or the daughter who can take them to the doctor to do the communication. So primary care is very important. It can detect very early where your health is, but I think prescriptions and some sort of reward in terms of fees paid up front goes a long way to encouraging primary care access.
Thank you, Moti. I might just cross back to Lourdes. You don't get the chance to be last this time. So maybe you can answer this question specifically. How do we support primary care? How do we support primary care better?
Yeah, I think it comes back to, like everyone's been saying, identifying those barriers, people who don't have time to go to the doctor, people who don't have the accessibility to travel and transport to get to the doctor, people who can't pay to get to the doctor and to their GP, and removing those barriers for some people and recognizing healthcare as a human right and not making people have to pay for their prescriptions either. Like we were mentioning before, it's really expensive for a lot of people and people can't afford it until maybe later in the year or maybe ever. So it's really important to identify those, fund our doctors so that people don't have to pay to see them, and fund trips to get to the doctors in the first place, fund people so that they don't have to make those tough decisions. Can I go and pick up the kids, or do I have to go to the GP? Those really tough decisions that no one should be making. I think we need to work on removing those and funding primary investment as a whole way more than we already do.
Thank you, Lourdes. I'll just take this question back to on John Tamahiri. I think it's a strange world, isn't it, John, where we can afford to spend $20 billion on COVID and we can't afford to properly fund primary care for type 2 diabetes, which is striking down our communities.
Yeah, look. my view on, there's 30,000 Māori in Auckland tonight that are not registered in any primary health organisation. There are 60,000 Māori that are enrolled but not engaged, right? 20% of our prescriptions in our clinic are not uplifted. So when you look at this, primary healthcare does not work for us the way it runs. So what do we do about that? Well, what we're doing is we've funded all our pop-up clinics, and we'll be dropping them in Decile 1 schoolyards and screening the kids as well as the parents with nurse practitioners who are able to hand out scripted medications from ventilators all the way through to ABs. So we're going to take primary healthcare to the community. And here's the other thing. The funding must follow the patient. It should not follow the practice anymore, because that would fix our problems. That would fix our problems. We all of a sudden, my money is not being spent by someone at the Ministry of Health, someone at the DHB, and someone at a PHO. And by the time the Māori or the Pacific Islander walks into a medical clinic, he's having to pay for somebody's already spent all his allocation without his consent. Not without his consent. That's state-sponsored theft. So we have to stop people reaching into Māori and Pacific Island pockets and bespoking the type of service we get, where we have no say in it. So when you get more consumer authority and power over what you're doing, you can then do what Waipareta is doing, which is dropping. We don't care what the GP service says in the area. What we care about is that the service is being taken in time, on time, and in a place that they're in and out of on their own flow. We're there because they're there. We're not there because we're making them get in a queue to come to me, travel to me, and then pay me. We have a totally different view. So it's extraordinarily important that we have this conversation, and I'm pleased that you've raised it. And so that's what we're doing. In terms of pharmaceuticals, I gave you the issue about e-prescriptions. Now, we know across our whānau order network in the North Island, with 6 PHOs, we know that we could get prescriptions e-scripted from a GP or a practice nurse and delivered within 24 hours to the address in Auckland, That works extraordinarily well for us. And guess what? It would be delivered free. It would be delivered free. Furthermore, the prescription charge would be waived. And that works for us. It works for us now at our own chemists because we do it on volume. But unless your community muscles up to organise itself to do that, it gets milked. And so, I know I've said a few harsh things about all GPs. It's not about all GPs. It's about the industrial age culture of running GP practices when digital is alive and well, and when allied trades, for the want of a better way to put it, can play a far more significant role in bringing primary health to our communities. Once again, I get back to honouring our nurses. They're outstanding. They've got to have their income lifted, and they've got to be acknowledged for their experience and their capacity. That's what the Māori Party wants.
Thank you, John, for that very eloquent summary of the problem. I'd like to just cross back to Matere now to make some final comments and to wrap up, and just with a final plea to our political colleagues not to forget the drugs and the need to fund the drugs if they should happen to get into power, to use their votes to make sure that this happens, because I think it's necessary. Matere.
Yeah, I think I used this phrase at the last symposium, which is, they were very grim data that we had presented at the beginning, and it would be easy to let that get us down. But I am the eternal optimist, and certainly hearing from some of our leaders this evening and having fantastic questions from those of you listening has lifted my spirits in this challenge that we have facing us here in South Auckland. So I want to thank each and every one of you for doing that for me, lifting me up, and knowing that we can look forward. And you've given me some great ideas. I'm very heartened that you all spoke about the social determinants and that how we need to address those root causes, including racism, for the rates of diabetes that we're seeing at the moment. I think you all talked about needing a different sort of workforce that's going to address this challenge, including using those people who are already working in our communities, whether that's in programs like through church or Energize, in our schools. You all talked about different models of care and taking advantage of the opportunities when they are available. Yes, John, drugs, I wrote drugs down. And, you know, I'm thinking, do we need to think about free medication for people with an HbA1c of greater than 65 or something like that if we're going to improve access to effective treatment for this, if we're going to prevent things. And champions, you all spoke about the need for champions, and having the Ashley Bloomfield getting up is something that I think that we could all advocate for here in South Auckland. But I think the overwhelming theme from tonight was the collective responsibility, that we're all in this together, and that we need to address, I guess, the mana of the people who are living with this disease and their whānau, and the intergenerational impact that it has. You all talked about that, about your grandfathers having it and not wanting to see the same story being repeated for your mokopuna. So I thank you for that as well. It is about the mana and addressing the mana munches that actually contribute to where we see ourselves today. So yeah, pessimistic data, but I'm optimistic after hearing from each and every one of our speakers tonight that we are all in this together and we're all wanting to do something better moving forward. So that was really fantastic. We still have some of the questions coming through, and I'm sorry that we weren't able to address all of them this evening, but I'm sure our speakers are happy to be contacted directly if you had more specific things that you wanted addressed. But if it's all right with you, I thought I would end again tonight with another small karakia to set us off on our evening and home to our whānau, and over the next coming weeks as we face other challenges in our lives. So kia tau, tō tātou rangi Māori, tō tātou manaakitanga, ki runga i ngā iwi katoa o Māori. Kia ora tātou.
Kia ora.
Kia ora.
Thank you, Matiri.
Thank you all.
Thank you.
Thank you for Māori.